Hello, I'm Robin Garcia. I'm a physicist living in Avignon in France, specialized in radiotherapy, and I'm head of department with 6 colleagues. We have 7 oncologists specialized in each site of the body, and we have in 95 started radiotherapy with a dedicated CT, and very soon we saw that breathing could be a problem. Firstly, we have studied the internal movement with the simulator and conclude very quickly that we could not manage anything with this information because we had one slice CT and very wrong images. So this first step was negative but interesting because we understood that we had to do something. And at this moment appear the work of the team of Memorial Sloan Kettering in New York, who wanted to start with spirometric breathing control. And we went in New York, we had some discussion, and so I decided to contact the specialist of spirometry, who were not from oncology domain, they were from pneumology domain. And so the first idea was to use a spirometer and to test. And we were afraid of doing something with such patients who have breathing difficulties. We didn't believe that we could reach a good result. That was the situation at the beginning. What helped us in the next steps is that we discovered that asking a patient to participate in a breathing management during radiotherapy was quite simple. Simple, maybe it's not the word, but when you practice, you discover it's quite simple to ask a patient to manage his breathing in collaboration with you to have a better treatment. Mainly we have to treat patients with big tumors, T3 mainly, and so we discover that the action of implementing breathing control in the department has to be oriented with clinical objectives. And if you think of what you want to obtain clinically, you understand what technique or method you should implement in your department to do something on breathing control. And because we started with lung, what interested us in the work of Memorial Sloan Kettering was that they based on deep inspiration, and inspiration is a magic attitude to extract healthy lung outside the irradiated zone, and this has a so important effect on protecting the lung that oncologists have a better situation to manage this patients who are in difficulty with their breathing. They have to receive irradiation. Normally they are tired at the end of the treatment, and when you apply a deep inspiration method, they finish their treatment in a better condition. It favors chemotherapy, it favors many things. So we discover with the 2-3 first patients very quickly a big effect. We don't think of result to cure patient, but effect on what happened during the course of treatment. And this quickly motivated everyone to continue in managing breath hold with spirometry. We built a better system with the software, and the day we included the video glasses, it means to give to the patient a feedback. It was easier, and we discovered that every patient were able to manage themselves their breathing. And we decided to organize the inclusion of breathing control with the patient with the first phase of preparation. So we are with the patient alone during around 55 minutes. explaining, training, until the patient is able alone to manage his own breathing. And after, the same day, but mainly we prefer to it the next day, a rendezvous at the city. The patient has trained a little at home, and already the city phases with breath hold is easy because the patient has got a training and is alone with the system. He has no problem to do it. So this was the history starting with lung. All patients with deep inspiration, breath hold, and lung irradiation had a good benefit. So oncologists tend to prescribe this method to patients who have one lung, to patients who have breathing difficulties, emphysema, and young patients. So the decision of prescription depends on the clinical management. But each patient who use this method have evidently an important benefit clinically. So while we were working on lung, we understood that all the thorax and abdomen part of the body is affected by internal movement of breathing, and so we can use the same method for other sites. And so in France, a national study was implemented on lung and breast. So we started doing breasts and discover many things. First, we do it for left breast. The clinical objective is to extract the heart from the tangential beams. It's easy to see the difference between the free breathing situation and the deep inspiration. The lung pushes the heart outside the tangential beam, and this is useful for some patients who have a special anatomy with the heart very close to tangential field to prevent cardiac problems. So clinicians, oncologists decide to prescribe a breath hold in breast treatment when they look at the dosimetry. It's the moment of decision. They look at dosimetry, they look and see that deviation heart is too important. So they ask the patient to come again in the department to do the breast hold preparation and redo the CT, have a better situation to that. What happened with women? It's not because they are women, but usually treatment on breast are on quite young persons, and they are able to do anything, and they are motivated to participate because they understand that they will gain in participating in that. But because these treatments are only based on two fields, tangential, the amount of monitor unit is the most important we can find in radiotherapy, because today many sites are with 4, 5, 6 fields. And but the women are able to maintain a breath hold easily 20-25 seconds. And so we have no difficulty to ask them a breath hold for the entire irradiation of tangential fields. What we discover also is that some patients have breast and mammary internal nodes, and the anterior fields also is towards the heart. But when you do a deep inspiration, the heart is pushed internally, but also is pushed feet direction. It means the quantity of heart under anterior field decreases a lot using the deep inspiration. So benefits we could not imagine at the beginning, but which we discover using dosimetry.